In this module, we're going to be discussing how phenotypic, endotypic, and underlying pathogenic mechanisms factor into the evaluation and treatment of severe asthma. We will review the clinical differentiation of asthma subgroups and the characterization of inflammation, pathways, and serum biomarkers, as well as its application to clinical practice. Let's start with the concept of differentiating asthma into subgroups. And in order to do that, we have to take a step back to some of the basics regarding what is asthma. We'll start with the physiologic definition, which is really the main underpinning of how we diagnose asthma in the clinic. First of all, there's airway hyperresponsiveness. In the real world, we may experience this by breathing in cold air and developing bronchospasm. In the laboratory, we use something called methicillin challenge to make this diagnosis precisely. Along with this, we see airflow limitation, which generally speaking in an asthmatic is a spontaneous event. It happens with virtually a variety of different triggers, and it will either spontaneously resolve or it may need to be reversed with a pharmacologic agent like a bronchodilator. If we move on to taking some of this physiologic background into the diagnosis, it's based on a constellation of different symptoms and some of the different diagnostic tests that we've talked about up to this point. One thing to keep in mind, and something we've learned very well over the past decade, is that asthma is not a clinically homogeneous condition. There's a lot of differences between various patients in terms of clinical presentation, in terms of their physiologic characteristics, one patient having very severe bronchospasm, another very mild. And then finally, how patients respond individually to different forms of therapy, particularly inhaled glucocorticoids. The time of asthma development seems to be a key factor in sorting out this process. Very young children tend to be relatively homogeneous with regard to how their disease presents. In other words, they tend to be allergic, they tend to have a gradation of airflow limitation, whereas in adults, it's a very, very mixed bag as what you find both clinically and physiologically. The idea of heterogeneity in asthma is not a new concept. In fact, I was able to identify an article going back 42 years written by Sheldon Spector and Dick Farr, published in the Journal of Allergy. The title of the article being, "The Heterogeneity of Asthmatic Patients, an Individualized Approach to Diagnosis and Treatment." And this was the first time that someone who had actually made the remark that asthma may have many different faces in how we approach it and how we treat it. Something that we have to keep in mind is that many of these different factors begin very early in life, and they evolve as a person grows older. Genetics plus the environment is something that occurs from the very onset of life. And based on these two factors, the interaction of the gene and the environmental factors, a variety of different proteins and biochemical pathways in cells, particularly inflammatory cells, will be wired and programmed to come out at various times in a person's life. Ultimately, these proteins and pathways in cells will result in a change in the person's physiology, potentially with bronchospasm, as well as symptoms, the symptoms that we call bronchial asthma. So one of our tasks as we try to generalize how a patient fits into a larger group is first of all define some of the key terms. First, what is a phenotype? A phenotype is a term we use frequently, and we all understand it to be an outward manifestation of how a disease state presents as a combination of genetics and environmental influences, as we mentioned earlier. But a term that you may not be familiar with is that of endotype, a more recently coined term which refers to a phenotype of a disease wherein we have a very good, or think we have a very good understanding of what the underlying pathogenic mechanisms really are. So it's now incumbent upon us to look at some of the data over the past decade and try to understand how we can separate asthma into clinical phenotypes. If you go back more than a decade ago, oftentimes we spoke of asthma as either being an allergic disease or a non-allergic disease. But then a group of investigators at the Severe Asthma Research Program, comprised of a large number of academic centers throughout the U.S., decided to take a different approach, in that they took an approach called unbiased hierarchical cluster analysis, where you may take 50 different features, or even up to 100, and pour them onto the table and see how they segregate in a large group of patients, typically 1,000 or more. And some of these characteristics we've touched on already would include clinical characteristics ranging from gender to age of onset of the disease, or even the severity of the disease, the physiology, and here we're referring to lung function or some measure of airway hyperresponsiveness. Triggers of asthma can include things like allergens, like cats and dust mites and pollens, tobacco, a very onerous trigger that may ultimately result in permanent airway obstruction, and even the kind of occupation that a person pursues. And then finally, sputum inflammation, looking at cells, both eosinophils and neutrophils, in an attempt to characterize what kind of a pathway is most involved in that person's individual case of asthma. When you take all of these different characteristics and you segregate them into groups, with no single feature playing a predominant role, you get a more balanced view of what that patient's clinical phenotype is comprised of. What we're looking at now is the first publication that came out of the Severe Asthma Research Program Hierarchical Phenotypic Clustering, where they looked at adults with asthma and showed that there were 5 different groups that asthma could be broken down into, based on age, presence or absence of obesity, the presence or absence of allergy, and finally the severity level of that patient. In cluster 1, it was an early onset disease, very allergic and mild in nature. The second group was also early onset, also allergic, but more moderate, requiring more medication in order to control the disease. With cluster 3, we now reach the patients who actually have severe asthma. Cluster 3 being a group of late onset obese patients, the majority being women who were not very allergic and had very severe disease. Cluster 4, early onset, highly allergic and very severe. And then finally the 5th cluster, which most people would consider to be the most difficult to treat with the worst outcomes, being a late onset form of the disease, minimally allergic with a very high level of severity. When we turn to children, the clustering tends to be a little bit different. I had touched on this issue earlier when I said children tend to have a more homogeneous picture. And throughout the United States, as well as attempts in Europe, when they've tried to cluster children with regards to their asthma, they're all associated with current or history of atopic dermatitis and an elevation of their total or specific allergen-related IgE. And this is a continuum, where the continuum really is based on the number of controller medications, their level of lung function, and their exhaled nitric oxide concentrations. But by and large, they don't really differentiate as much as the adults with asthma. What I'm going to show you now are really our attempts to endotype what we consider to be some of the key groupings of patients who do have severe asthma. Group 1 being that which we saw earlier, an early onset allergic form of asthma. And again, keep in mind that these 3 groupings all have severe asthma. These patients usually have a history of food allergy, most likely egg or milk. They may have had atopic dermatitis, very commonly. And finally, they'll develop allergic rhinitis or conjunctivitis before finally developing asthma. The next grouping we call late onset minimally allergic or minimally atopic eosinophilic asthma. These patients have a form of disease that often follows a severe bronchial infection, followed by the onset of recurring sinus infections. When these patients are examined, they frequently have chronic rhinosinusitis with nasal polyps. They tend to have more severe airways obstruction than any of the other groups we've looked at. And there is a subset called aspirin-exacerbated respiratory disease, where patients have all of the above features. But in addition to that, they also have an exacerbation of their nasal obstruction or asthma in response to things like nonsteroidal anti-inflammatory drugs. And the final endotype would be late onset non-eosinophilic. This is more defined by what it's not than what it is. What it's not is we don't find markers of eosinophilia. We don't find markers of IL-4 or 13, such as exhaled nitric oxide. And typically, these people may have the involvement of chronic or recurrent lower respiratory tract infections and gastroesophageal reflux disease. Now, the discussion that we've been having about phenotypes and clusters of asthmatics takes us to the next topic, which is really to characterize better the inflammatory pathways and biomarkers that we use to differentiate asthmatics clinically. We're going to break it down very simply into 2 pathways of asthma. The first being what we call type 2, previously called Th2 or T2 type of asthma, which comprises about 50 to 70% of all patients. The other being a non-type 2 pathway, which includes the other 30 to 40% of asthmatics. We'll start with an issue of cytokines. The cytokines in type 2 asthma are typically characterized as being interleukin 4, 5, and 13. These cytokines are derived from Th2 cells, from innate lymphoid cell type 2 or ILC2 cells, and from mast cells. One of the very important actions of IL-4, 5, and 13 is to attract eosinophils from the bone marrow and then let them get into the lung tissue. So we're going to see variable levels of eosinophils in the sputum, in the airway tissue, and in the blood of these patients. And a very large proportion, not all, but most, will have an elevation of their total IgE and specific IgE to a variety of different allergens, from dust mites to animal danders to mold to others. Now, again, as I mentioned earlier, non-type 2 is a much more difficult pathway to characterize. We know that the IL-4, 5, and 13 are not involved in this pathway, and it's been speculated, perhaps, that IL-17 may be a very important contributor to this pathway, perhaps GM-CSF as well. These patients frequently have an underlying related bronchial infection, again, but not always. And with regard to the cellular infiltrate that we find in patients with non-type 2 asthma, typically there are no eosinophils, but rather they may have an increase in sputum neutrophils, which we define as greater than 60% of the cell types in the induced sputum. And then finally, these patients are not allergic. They may have a random skin test to a select pollen, but we know that in these patients, allergy does not seem to be driving the disease, and typically there is no increase in total or specific IgE. So how do we utilize these inflammatory markers, and what are we really looking for? Well, one thing that we know is that inflammatory markers have contributed to our understanding of how to predict which patients will be more severe and how well they'll be responsive to some of the therapies that we commonly use. There's a number of different ways that we can characterize patients using biomarkers. We can do genotyping. We can actually sample cytokines in the blood or in the airway tissue. We can look at cell populations in the airway, in the tissue, and finally in the blood. We can look at a variety of different exhaled gases, but predominantly exhaled nitric oxide. And then finally, we can sample serum proteins, which to date have included periostin and dipeptidyl peptidase 4, also known as DPP4. So I think it's useful to discuss what is an ideal biomarker. We probably haven't identified one yet, but we're in the process of trying to hone and refine our understanding of asthma to the point where we can improve upon the biomarkers that we're using. A biomarker should be reproducible. So if you look at it at 2 points in time, you'll be able to follow it adequately. It should be accurate. It should be accessible, either a blood test or preferably something that can be obtained easily. It should correlate with the severity of the disease at baseline and hopefully reflect a responsiveness to therapy. It should come at a reasonable cost and ultimately be non-invasive. That's a lot to ask for. But we're going to be looking at some of the data we have with the biomarkers that we do have, starting with the eosinophil as an inflammatory biomarker. There are variable numbers of blood and airway eosinophils present in patients with the type 2 cytokine profile, again meaning IL-4, 5, and 13, and it's probably related to the level of type 2 activation due to either allergen exposure or some other driver of the inflammatory process. Something we've learned over the past couple of years is that eosinophils in the blood and sputum can be correlated with the frequency of asthma exacerbations, the degree of airflow limitation, and finally the presence and severity of chronic rhinosinusitis with nasal polyposis, all of the above being very important in characterizing a severe asthmatic. When we talk about understanding how blood eosinophils and sputum eosinophils come into play regarding the evaluation of the severe asthmatic, it's important to understand what kind of a threshold are we going to use. So we're going to look at the parameter, either being sputum or blood eosinophils. We're going to look at different threshold values, the derived sensitivity of using that threshold, and finally the specificity. Now historically we've used a level of 2% sputum eosinophils to establish that asthma has an eosinophilic phenotype. Using this approach, we have a sensitivity of picking up eosinophilic asthma using bronchoscopy as the gold standard of only 54%, although as you can see the specificity is extremely high. If we drop that to the neighborhood of about 1%, and actually the data in this study was a little bit less than 1%, the sensitivity rises considerably without sacrificing specificity. Very similarly, we've historically used a level of 300 to 400 eosinophils as a cutoff for identifying a type 2 inflammatory pathway. But in a study that was published, again, dropping that threshold to 230 eosinophils per microliter of blood allows you to have a much higher level of sensitivity, all the way down to 76%, without at all sacrificing specificity. So keep in mind that when you look at papers and read the published literature, understanding the threshold and how it was derived are important. This is an example of how we can employ blood eosinophils to get an idea of what the relative risk is for an exacerbation. Data published in the last couple of years on this slide shows that as we look at different strata of eosinophils, starting with 100 cells and then looking at 100 cell increments all the way up to greater than 1,000 eosinophils, we can see that the relative risks of an exacerbation rise considerably when you get into the neighborhood of 3 to 4 to 500 cells. And below that level, you don't see a large increase in the relative risk. Now, sputum eosinophils have also been shown independently to be a very important predictor of patients who have frequent asthma exacerbations, defined as more than 2 exacerbations per year requiring oral corticosteroids. This was a large collaborative study published in Europe where they tried to characterize what features really helped identify the patients that we should be most worried about. What we're looking at is a parameter, ICS dose, oral steroid dose, the asthma control questionnaire score, and finally, sputum eosinophils and the percent that were found in their sputum induction. And we can see comparing the non-frequent exacerbators with patients who exacerbated more than twice per year, there are some striking differences in the amount of inhaled steroid, the requirement of oral steroid, the questionnaire score that was yielded, but particularly with regard to sputum eosinophils, which was 25% plus in the patients who exacerbated frequently, but only 8.2% in the other patients. So I think this is, again, another very accurate way and predictive way of identifying these patients. We know that not all patients have type 2 pathophysiology, and certainly many people have discussed and written about the role of the sputum neutrophil as an alternative inflammatory biomarker to identify the other group of patients. We're defining sputum neutrophilia as greater than 60% of the total white blood cells in the sputum of this subgroup. Most of the time, patients with the most severe type of asthma seem to have a combination of eosinophilia plus neutrophilia, although there is a small isolated group of patients who have neutrophilia alone. But one thing you have to keep in mind when you're examining the results of this kind of test is that a number of other factors may have prominent influence over the neutrophil count in the sputum, including the recent use of inhaled corticosteroids, things like air pollution, particularly ozone, which is a known elicitor of neutrophilic inflammation. Of course, lower respiratory tract infections do bring neutrophils into the airway, fungi as well, and finally, even gastroesophageal reflux has been identified as a trigger of neutrophilia. So one thing we have to keep in mind is that this is a very nonspecific marker, but again, it's something that we can certainly take into account when trying to characterize the phenotype of a patient. Serum proteins have been very actively pursued as a marker or biomarker of inflammation in patients who have asthma. We know that cytokines can be examined, but it's very difficult to identify them in the blood and the sputum. Not only difficult, but also prone to inaccuracies. If we could identify a surrogate for that cell, or a surrogate for the cytokine that we're trying to identify in the blood, then we've happened upon something that's much more convenient, much easier for the practicing physician. Some data has shown that airway interleukin-13 correlates very well with things like periostin and dipeptidyl peptidase 4. Both of these are epithelial-derived proteins that respond to the presence of interleukin-13. So as the patient develops inflammation that's related to interleukin-13, the levels of these proteins in the serum will rise. And they've been shown to be both identifiers of this particular subtype of asthma as well as predictive of response to agents which do inhibit interleukin-13. It may be that we'll never see these particular serum proteins as diagnostic tests, but something we do have, which is a very convenient test, if you happen to own the technology, is measurement of exhaled nitric oxide as a very good marker of the type 2 pathway. Now, people often believe that exhaled nitric oxide reflects eosinophilic inflammation, and in fact there is a correlation. But we know that exhaled nitric oxide is produced by the epithelium and responds to interleukin-13 very much the way that the epithelium produced periostin and DPP4. So as I said, there may be a connection between sputum and blood eosinophil numbers, and it's a pretty reproducible marker of the Th2 phenotype, somewhere in the neighborhood of about 20%. This is important because we're going to be following this over time, so reproducibility is an issue. Something that we've been able to demonstrate in a number of studies, that people who have a distinctly higher level of exhaled nitric oxide, around the number of 33 parts per billion, demonstrate a much stronger response to inhaled corticosteroids. And conversely, if patients have a much lower level of exhaled nitric oxide, in the neighborhood of 20 or 22, they've been able to successfully discontinue their inhaled corticosteroid dosing. So this tells us that one way of identifying a patient who is in fact steroid responsive or not in fact in need of steroids is to perform a test identifying how much nitric oxide is present. I'm going to finish this module with a slide showing the correspondence of blood eosinophil level to the success of interleukin-5 inhibition. And the reason I'm picking this particular study is because we know that IL-5 inhibitors, anti-IL-5 drugs like mepolizumab and rusolizumab and benralizumab, all block interleukin-5 activity from drawing eosinophils into the blood and ultimately into the airway. In this particular study, we can look across a range of different eosinophil counts. And what we in fact find is in the lower ranges of eosinophil counts, below 200, below 300, and below 400, there's no real response to the rusolizumab and IL-5 inhibitor. Finally, when we get to the level of 400 eosinophils, we see that there's a very robust amount of bronchodilation with improvement in FEV1, showing that in fact when you do inhibit IL-5 and eosinophilia in a patient with lots of eosinophils to start with, you're going to get a much better response than those patients who have a much lower level of this biomarker. This brings us to the conclusion of this module, and let's summarize some of the things that we've discussed today. Number one, there's been a lot of excellent clinical research in the past few years that's really attempted to better understand this heterogeneity that we've been discussing. Number two, there are a lot of different clinical and physiologic characteristics, along with certain inflammatory markers, that we can use to distinguish asthmatics as to which group they fall into. Three, the precise use of biomarkers really helps facilitate what kind of an inflammatory pathway the patient has going on in their particular case of asthma, and allowing the physician then to determine what might be the best medication to use, whether it be an inhaled corticosteroid or whether a biologic might be indicated. And then finally, number four, as we discover new biomarkers and refine the use of the ones that we presently have in our armamentarium in treating this disease, I think we can expect to see not only new medications, but better outcomes with respect to severe asthma.